And this is the afternoon session. Hope you enjoyed the fine food at your own institutions. This afternoon, we have a combined mini think tank with the networks and First Clinical Question Group. From the First Clinical Question Group, there was a group of us over the last some months that got together on multiple 8 a.m., I guess it was Wednesday morning calls, and hammered around a few items and thought through a few interesting concepts. And we're going to hear a little bit more about that from Dave Morrow coming up. We tried to figure out a concept that could be somewhat agnostic and not too controversial, but something that could have a major impact on the overall outcomes of shock patients. And then Alex, why don't you just give us a high altitude view of what's coming up from your speakers?
Sure. Can we actually show the agenda real quickly, Samia? So obviously we're going to just kind of start off with the overview, then look at very briefly, yeah, there we go, what the vascular safety bundle is and what the trial will be composed of, and the registry concept. And Dave will kind of lead that off. And I think this will be important because we obviously really wanted to push from the theoretical into a practical and actually have some achievable objectives in the short term. We'll move into a little bit of the lean CRF, which has been discussed, and Mark Samsky is going to share not all of it, but kind of focus in on the vascular safety piece there. And then we'll transition into talking about networks and coalitions, and just like Ian kind of recapped what his group has been doing, myself and Alistair have been participating in the network group, trying to determine what some agreement and definitions of what a shock protocol, team, center, network would be based on, I hate to use the word expert, but some general best consensus, and then identify sites that are situated not just for clinical care, but to participate in a research registry, pilot trials and such. And then you can see the sub discussions underneath there is where the money is going to come from, and how this is going to be organized. And then a final wrap up with both Alistair and Ian. So I'll turn it back to you, Ian, but otherwise we can probably dive in to the beginning portion with Dave.
Yeah, I think we should keep things moving, and our next speaker is Dave Morrow from Brigham's and Women's, and he's going to give us a concise review of the vascular safety bundle trial / registry concept.
All right, just a quick check that you are indeed seeing my slides.
Yes, they're beautiful.
Perfect. All right. And so I think, as you just heard from Ian and Alex, we started down this road a little bit over a year ago, and what you're really going to hear about is a pyramid that has a fairly broad and ambitious view for improving safety in the care of patients with cardiogenic shock. But also, really, our focus for today is going to be on setting the groundwork for a deliverable that we can actually start to execute in the coming months and not year. And the background is familiar to this group, but to put us all on the same level as we start, we've all been at it now for many decades, trying to improve our care of patients with cardiogenic shock. And while we have definitely made some strides, there is still unacceptable rates of morbidity and mortality in this group of patients that we care for. And everything that we do for them to try and make them better carries a balance of benefits against risks of these therapies. And we have a litany of best practices that we all use in our clinical care. But we recognize at the same time that those are largely and mostly not driven by rigorously controlled evidence, because these studies are quite difficult to execute. And so we in our group, really as an expression of the entirety of the SHOC consortium at CSRC, have sought to develop a platform of trials to investigate processes of care to maximize efficacy and mitigate the risks of therapy for cardiogenic shock. And that is our overarching high-level goal. And then as we drill down to the focus for today, we all agree that improving safety of temporary mechanical circulatory support is an important goal that is of very broad interest to all of the stakeholders engaged in CSRC. And then if we start from that level, we can focus even more down on one aspect of the balance of risks and benefits of mechanical circulatory support, and that is around bleeding as a complication of our vascular access. And we all know from culprit shock and caring for this specific group of patients with AMI cardiogenic shock undergoing invasive therapies that half of the deaths occurred in the first 48 hours and corresponded with a high incidence of severe bleeding. We know from multiple domains in cardiovascular medicine that bleeding is associated with the risk of death, whether it's in the setting of pharmacotherapy or interventional therapies. And from some in this group, we have observed that if we can modify practice in a way that reduces bleeding, that has been associated with an improvement in survival. And so it is a plausible hypothesis that a reduction in bleeding in patients with shock and mechanical circulatory support might also decrease mortality and improve outcomes in this population. And so what our group has proposed as our broadest concept, taking a step back up again, is toward a platform of trials, sequentially implemented. While one is being rolled out, the next one can be planned and then efficiently initiated, that we can learn iteratively from each step that we take and build on the evidence of each trial. And ultimately, that high-level goal, again, is to investigate processes of care that will improve the balance of efficacy and safety in managing patients with cardiogenic shock. And particularly, our focus now is on mechanical circulatory support. And the first trial, as many of you heard at SKY, is to design and implement a stepped wedge cluster randomized trial of a vascular access safety bundle as that initial effort in a platform that would grow over time. And the very first step in achieving that goal is to implement a vascular access module of the lean core CRF for shock, which we're going to hear about in a second from Mark Samsky and Bill Abraham in the work of that entire working group. And our aim in that first step is to road test the module and gather data on current practice. And so while this gives you an overall view of where we're headed, the rest of this session beyond my lecture is really going to focus on this element, which is actually setting up a registry and launching this initial road test to enable us to progress toward a randomized trial. And so now in the remainder of my time, I'm going to take you back up to the level of the trial to give you a framework of where we're headed. That will be the background for the conversation of the rest of the afternoon. And so our objective proposed for the Vascular Access Safety Bundle, RCT, is to assess the efficacy and safety of a vascular access safety package to reduce bleeding complications and improve survival among patients planned to undergo mechanical circulatory support in one of two settings. These could be separate trials, suspected cardiogenic shock or high-risk PCI. Fortunately, through the work of many on this call, we do have a well-described package of vascular access techniques that can lower the risk of access site bleeding, and has done so in other interventional settings. And these techniques include all those that you're very familiar with: ultrasound, microvascular puncture, radiographic confirmation, and ultimately angiographic confirmation of your positioning. While these tools are pretty well established and there are observational data to suggest their success, as well as in narrow domains clinical trials, Abdullah, who's on this call, Dumajli, showed us in 2017 that only 11% of interventionalists use micropuncture more than 90% of the time. And only 36% were using both fluoroscopy and ultrasound for the femoral access. And so despite the fact that there is at least some base of evidence for this practice, we recognize that it's not sufficient to have swayed most practitioners. And this is also a survey of what people think they're doing, and not necessarily even what they're doing. And in general, our surveys are more optimistic than actual practice. And that's one of the purposes and importance of the registry that we're going to talk about. And so in this initial phase, we would propose that this would be a stepped wedge cluster randomized design, randomized at the site level to the timing of transition from their existing standard of care to the investigational vascular access safety package. All centers would contribute both to the control and investigational group at randomly allocated time of transition. The primary safety outcome is vascular access site bleeding. The primary efficacy outcome is death from any cause. And there would, of course, be a variety of additional secondary endpoints that would flesh out the potential benefits of this process intervention. The entry criteria, at least the key ones, are very simple. It really is aimed to be a broadly inclusive trial of patients with shock of suspected cardiogenic etiology, or again, potentially in a stratified or a separate study, high-risk PCI, and plan for mechanical circulatory support via femoral access. You're excluded if you already have femoral access in place, that access site bleeding was already present prior to screening, or ongoing cardiopulmonary resuscitation, or other reasons that, that survival is not expected. And so this is the 30,000-foot view of all of the objectives and general scope that I just described to you, that gives it in our traditional trial framework. But let me show you, for those who aren't familiar, how a stepped wedge cluster randomization can work. So each center is randomized at the site level to that timing of transition. And the strength of this design is that there are no specific requirements regarding the standard of care preceding the intervention. In fact, there's some strength in having heterogeneous care across the sites. If every single one of the sites was already using the full vascular access bundle in 90% of their patients, we actually wouldn't really be asking a meaningful question in those centers. So we would expect some heterogeneity across the centers. And then at a randomly allocated time within the study, each center transitions into the vascular access safety bundle, allowing you to use that center's patients essentially as a control for the subsequent intervention, as well as looking across sites pre-post in the introduction of the intervention. And so in summary, we all care about safety. That is certainly a central goal for all of the stakeholders in this field. The cluster randomized design that we have proposed leverages the variability in current practice to study a process intervention. It is facile for a pragmatic trial design that could even be integrated on top of a registry, which is another important aspect of the work that CSRC and the AHA members who are participating in this call this afternoon have been working on. But our first step here is to test the CRF module that people have been putting hard work into, and to capture some pilot data to help us in planning this trial that we might all hope to be working on in the not too distant future. So I will leave it for that. This is really, again, the foundation for devoting the rest of the discussion this afternoon to the collection of the pilot data as the underpinning for the trial. So I'll turn back to you, Ian.
All right, well, thank you very much for that overview. Try to, if you guys have comments or questions, keep it, write it down on a piece of paper so we can add it to the discussion that's going to occur after the next presentation. And that's going to be Mark Samsky, who's going to give us a review of the vascular safety module of the Lean Core CRF. Mark, it's in your hands.
Hopefully you guys can see my slides now.
You can, you're just in the presenter mode though, Mark.
Boy. I've never actually been able to get presenter mode to pop up when I wanted to, and sure enough. How about now?
Are you using two screens?
Try slideshow again, because that doesn't look like presenter mode.
No, it's now it's recording what everyone's saying. Try this.
Any teenagers on the call that can assist?
Hey, Sam's
I'm probably as close as
teenager.
probably as close as they get to this.
Oh, that looks good.
All right.
Yeah.
So I'm going to be talking about our work on creating the Lean Core CRF and specifically the vascular access safety module related. So the overall mission of our working group was really to create the leanest of lean CRFs that can be used in future cardiogenic shock trials and registries, and to standardize the associated data structure and definitions for use. And we're calling that group the SHARC group, the Shock Academic Research Consortium. And really, we're trying to do this in a way that's agnostic to the etiology of shock. It's agnostic to any potential therapeutics that are either used now or in the future. And we're hoping to do this in order to reduce redundancy and increase the efficiency of future research, with really the hope that we can harmonize data across many separate initiatives if we can really hone in on what is important data to collect. And so this is a slide that we showed last fall. This is our working group. We've got a representation of stakeholders across the shock space. We've got international collaborators as well. The components that went into formation of the Lean Core CRF, we used a variety of 5 registries and randomized controlled trials that are listed here. And really what we were trying to do is identify the data elements that were common across all 5 of the initiatives, and then add in what the group thought was important that may not have been included in any of those separate initiatives. So in order to do so, essentially we took the data from each of the CRFs, created what we think is a very lean document, and then on top of the core CRF, we've built out several different modules for different components of the care of a patient of shock that can hopefully be used for future research. And so those include advanced imaging, invasive angiography, MCS, a new one, vascular access, and then invasive hemodynamics. And again, the intent was to try to standardize data collection, reduce redundancy, increase efficiency, reduce costs, and hopefully really improve the quality of evidence and the ability to aggregate data. Here's our timeline, which we also showed in the fall. The blue boxes highlight the steps that are done. The red is what still needs to be done. We really think we do have a document that's ready for circulation, and I think the CSRC leadership team circulated it earlier this week, and it's okay if you haven't had a chance to review it yet. We'll have ample opportunity to do that as the winter progresses and into the early spring. We're hoping to have this written up and prepared for a manuscript submission, I'd say late spring. So in terms of the vascular access safety module, it was a slightly different approach, and that's mostly because this is, I think, a novel concept when it comes to research in the shock space, and I think Dave highlighted that quite well. When I was browsing through the case report forms that were used to build the CRF, none of those really incorporate anything regarding vascular access and safety. Obviously, all of them were interested in capturing adverse events associated with vascular access, but I don't think any of them really interrogated the arteriotomy well, as a cause of potentially why. So, bleeding was obviously common amongst the CRFs. Whether or not there was a vascular event that required an intervention was captured, but few data elements on actually what happened to the blood vessel. And so that was really sort of a ground up process in creating this particular module. So again, consistent with the overall working group's mission, the requirements and the intent of the vascular safety module was for it to be iterative, so it could be used over and over again for each procedure that a patient undergoes. It's again agnostic to all therapeutics, and we're really interested in interrogating the arteriotomy itself, and then to try and assess and quantify bleeding and associated treatments, and then ultimately capture the size of the device that was used in order to do those things. So here is the data that we've proposed to be collected related to the arteriotomy. We're looking at laterality, the actual vessel, whether or not ultrasound was used, whether or not fluoroscopy was used, whether or not a micropuncture needle was used, and whether or not a confirmatory microangiogram was performed. In order to quantify bleeding and associated treatments, you can see here again, we're looking at the access site, whether or not there was a bleeding event, whether or not what the change in hemoglobin was, if the bleeding event was treated with a transfusion or with another treatment, and then whether or not there was imaging used to diagnose the event. And here they are together, and at the bottom you added on here just how we decided to capture the size of the device, or the largest device used in each of the arteries of the leg. So that's what I have. Thanks everyone for the opportunity to present, and looking forward to the discussion.
All right, that was good. Now we have, I think by my watch, we have about 35 minutes to go over any issues along here. We've tried to put together something that is feasible to do, something that could, almost regardless of whether it works, we could see the difference or not. It's, if we can just get everyone with improved technique at the end, that may be a success on its own, so that we're working on level playing fields as we move forward. The step wedge design is interesting because you obviate the need for consent forms because it's on an institutional basis. You literally could have all comers. And it also allows the same group that's doing one thing to be planning another thing to follow up. So if you wanted to study removal technique or other aspects, you could then just march that in as the next step in the step wedge behind that, and just keep going with iterative concepts to test. And On the other hand, if you didn't like the whole step wedge thing and you just wanted to have a uniform collection tool to use across registries and across trials, to help get a handle on what's going on at the arterotomy site, this could provide a common basis so that it could be compared across trials. You know, the various results that we've seen in various mechanical support papers may be explained in part by variations in how these devices were put in between small groups of people that were very proficient and very precise versus larger collections of sites that were relatively loose with their technique and therefore had a different outcome. But I'm not going to sit here and talk. The idea is to get everyone else talking, and me just moderating and keeping everyone from getting into a complete brawl.
Thanks, Ian. And maybe I make one point about the vascular access module for the CRF. You know, as you give your feedback, we conceive this to be exactly what it is, a module that can be used in a variety of settings. So in this next session, we'll spend some time talking about different domains where it might be fit in, but it could be used in conjunction with the core CRF for the AHA registry. It could be used in conjunction with a randomized clinical trial, such as the 2 Abiomed trials. It could be used in a high-risk PCI population. Or we also will talk about whether we have a standalone smaller pilot registry to help gather data to inform the cluster randomized trial that we're proposing. So we'd love your feedback on the module. Are there other things that we need to put in it? We tried to balance the right degree of complexity, but also not make it overwhelming. Chuck, were you gonna?
Yeah, I just unmuted because I wanted to jump in. Great start. I love the lean CRF modules. I think the modules probably, you've taken all those different databases and looked at it all and come up with a nice lean list of safety endpoints. I think that's great. My concern's more really with the first part, which is just the design of the study. And I'll just throw a couple things out. Other people can add to it. If the sites are used, and maybe you can correct me, maybe I don't quite understand the stepped wedge approach, but if sites are randomized to different, look like to me, different phases of when you actually transition from your standard of care to best practices, that would be in the protocol, which is the active part of the study. There may be, if you go after the really good sites in the country, you may find that a lot of them are already using those best practices. So their standard of care is not going to look much different than what you get after they transition, which will reduce your chances, of course, of seeing any difference in outcomes. But I think the biggest minefield in there is how do you control, which you won't be able to, for the variation in different shock procedures that are done. Some places like to start with a balloon pump and escalate. Other places go early impella. Other places do inotropes and escalate. And there are different ways people handle doing their primary PCI procedures. And, you know, NCSI spent a number of years gathering best practices for AMI shock and have come up with a number of things like, you know, early use of, you know, pre-PCI unloading, whether you believe in it or not. Pre-PCI unloading, if you are going to use impella, the use of right heart catheterization, or is there going to be anything around that? You know, protocols for escalation to identify right heart failure. About 15% of patients that die of cardiogenic shock actually die of unrecognized right heart failure. So there's all these best practices that have kind of come out of the NCSI experience that could greatly influence your second endpoint, which is mortality. The first endpoint, I think, safety, bleeding and vascular complications. That's pretty easy. That's pretty straightforward. You can look at that. That's really what you're testing. But that second endpoint you had in on mortality could be really impacted by all these other factors, you know, best practices on what active treatment you actually use for shock in trying to impact mortality. And then the other minefield in there is just that probably should be some rules of the road getting into it for the sites getting in that, or the investigators involved in the study, that you put some rules in there that we're not going to go into this thing again where we start comparing, balloon pump to Impella to ECMO, all this, because this is not the setting for doing device versus device or treatment strategy versus treatment strategy comparisons to support an agenda that somebody might have. So it needs to be used for the right purpose. I think it's a cool idea, but I think if you could stick to the safety part, probably leave mortality out of it and really just look at the safety endpoints as your primary objective. And maybe have a mix of sites where you have highly experienced shock centers and less experienced shock centers. So you get some in there that maybe aren't already have adopted these best practices. So you have a better chance of seeing a delta. Anyway, those are just my, oh, and the consent. Ian, I wasn't sure what you said about the consent. If you're actively collecting data with the intent to publish, you're going to have to consent these patients, and you have to, unless you're going to try to classify it as some kind of operational quality initiative that the hospitals will be doing, and not a clinical research study.
Yeah, just I guess I'll hit a few comments, and then I guess Dave, he's holding himself back from comments too. The consent issue is, the thought was it was mainly the whole institution is switching, and how did that affect things? We clearly did not want to compare one device against another device. We clearly did not want to just have 10 of the top sites from, Protect 3 or 4 or the Detroit Shock Initiative that had really thought about a lot of these concepts and probably do a lot of these concepts. I think the most valuable thing would be to get a mixed bag of people and really show people that if you go with these sort of relatively well-developed ideas of how to get access, that'll translate into a safer outcome. And still, as some of the data that was discussed earlier, how despite a lot of people talking about doing all the right things, when you actually look at them, they're not. That's a minority of the population and of interventionalists. And when those good things don't happen in real sick patients, it may drive some of the mortality. And I understand what you say about mortality and shock can be a little bit of a slippery slope to try to pick through, but I think it's an important concept because it's not like in the early days of ReaPro where they said, the bleeding will take care of that. We'll just give them some transfusions and everyone will do better. There's a lot more to bleeding than just another bag of blood. But I don't know, Dave, what do you got comments?
No surprise, Chuck, you hit on all of these key issues. And, I'd say that actually, as Ian was just articulating, that really the aim is to get a very broad group of sites. And because it is a pragmatic design that could be layered on top of a registry, you could, for example, do your randomized trial on top of the AHA registry and use the registry as the backbone, for example. It is to get a very broad group of sites, and that's actually one of the main reasons for collecting some pilot data, is to see where people are actually practicing compared to the pilot. And we would aim for heterogeneity to bring the whole world up to the Innovum, the Tufts level, and the Henry Ford level. And then the second about practice variation is quite important too. That's one of the strengths of the stepped wedge design, is that that each comparison each institution functions as their own control. So your background practices around your device therapy, the risk you run with a stepped wedge is if other practice changes. So if you were using all balloon pumps in January, February, March, and then you switch to all ECMO in June, you'd be in trouble. But as long as that background pattern of care is relatively stable over the period that you're studying it, within each center, your practice is your practice before and after, except that you're using the vascular access safety bundle. So it inherently builds that in as a control. And in fact, you'd want a variety of background practices. And as Ian said too, the purpose here is really to study this process improvement and not to compare other aspects of care.
Yeah, Chuck, I'll jump in on a couple because you really did sort of hit all the bullseyes pretty much. I think
It's a good shot.
the key from the group that I think has been most informed is of this whole CSRC initiative starting to actually do things. We have to be very focused, start with small manageable bites. So this is not the whole shark, but in fact, it's a very discrete part of it that we can concentrate on. This is also clearly not intended for anything but agnostic to device per se, other than the French size of the device. This is not a comparison of device to device. It's the other side, which is part of the CSRC, which is the safety side. And it's an emphasis not on effectiveness, but on understanding to what degree can there be a systematic approach to understanding safety and improving it, kind of all in the same effort, where vascular access, and this is not news. I mean, TAVR, there are many other larger bore areas that are life-saving, but that have paid a lot of attention ultimately to the safety of the vascular tree in order to be life-saving. So I think that's really the right spirit. I think the informed consent aspect, you certainly are correct. If this is done with an intention to publish data, then this is more than just quality metrics. But an IRB may be very willing to see this as an opportunity as well, in that it is a quality path for an exemption as long as it's de-identified data. So I think there's a reality there, in the same way that professional society registries, I'll pick on the NCDR for today because I see Marielle here. So, but the NCDR, publishes data and intends to publish data, but does not get informed consent. But they do it right. They do it as a process. And I think there's a process, there's a window there for this type of agnostic safety evidence to ultimately move forward without necessarily getting consent. Now, that being said, I think it was mentioned that this would be a very reasonable fit for anyone in high-risk PCI. If you're using, I'll pick on you, if you're using an Impella, or if you're using an Impella in a shock setting for your own purposes, to understand to what degree do the same centers who do a stand-up job under elective circumstances manage to run the same quality of vascular access when it's really urgent in shock. So I think there are a lot of possible permutations here, but fundamentally, as always, as is the nature of this collaboration, the goal here is to generate value for everybody. And the goal here is not to put device data into anybody's hands, but to better understand your own device under elective and acute settings. That would be an obvious outcome that might be of value, to a manufacturer. Whereas ultimately, I think for the big picture, from a professional point of view, understanding the degree to which we have centers who can learn, who can get better, and then some centers who are already so good that they don't get better, that all of that becomes the real landscape for the safety side of patients who really come in the sickest pathway and need mechanical support.
Naveen, you got your mic off?
Let me make a few comments here. So first of all, I just wanted to say, I thought the proposal was terrific. I think the idea of targeting vascular safety makes a lot of sense. It's extremely impactful for hard endpoints for patients, for clinical outcomes. And it's a large unmet need in this space. So I think it's a terrific first step for CSRC to kind of move into, mobilizing the registry and then converting it into action items that then lead to improved outcomes. So I just want to applaud the group for thinking about that. I will echo some of Chuck's comments. I think some of the concerns just from having looked at shock data now for quite a while and trying to parse it all together, as you know, David, I mean, this stuff can turn into a mound of spaghetti very quickly. And somewhere in there's a meatball, but it's hard to find sometimes. And, I think the thing to do actually is what Mitch said, which is to stay really focused. I think that, shock right now is so broad. The definition is broad, and there's already, I think 15, 20 people on this call that are working on just defining the entity. And I think that parsing out MI versus heart failure is going to be really key. And I think vascular safety seems to fit really well for that AMI shock cohort. And there's enough work to be done just in that small subset. I wouldn't call it a small subset, but that subset of shock patients. Because once you start getting into the non-AMI patient populations, there's so many potential confounders. Even if you take bleeding as an endpoint, every ECMO patient gets a blood transfusion. And it's mostly just to keep circulatory volume up because you've now put half the circulating volume into a pump. So I think that's where some of the definitions may need to be modified or tailored. I think the study population should be pared down to a population where an intervention is being performed like MI, that obviously involves vascular safety, vascular access, and also has an intervention that, that avoids a lot of the confounding of other complex interventions. And you'll see less ECMO use there. And the only reason I say that's important is because, as the operators on this call know, once you start putting in ECMO, the vascular total French size starts to go up, from something that sounds like 15 French for the arterial. It turns out you put in 125 French worth of cannulas into one patient. And, the bleeding and the antegrade perfusion techniques and all of those things are still under intense investigation with very limited data sets. So I think if you really want to move the dial, I would say focus on AMI shock. I do like the idea of a stepped approach. I love the pairwise comparison to what you were doing before versus after. Makes a lot of sense to me. But I do think focusing, as Mitch said, and then as Chuck said, making sure that, I think Chuck's saying the same thing in a different way, just making sure that you're carving down into the exact right group where an intervention like a vascular bundle will have a high impact. But I really applaud the group. I'm excited about this initiative. I think the safety bundle is a great idea.
Yeah, no, thanks. No, all very cogent advice. And I think we are starting at least with the concept as a broad one, and with opportunity to refine as we go down. And a lot of it will depend on sites, resourcing, where the opportunities go. But I think, as you just pointed out, there are a variety of places where this could fit, and your advice to focus is a good one.
So David, I'm going to throw out one other pitch for our CSRC perspective, which is if this vascular safety bundle goes forward with an early registry network sort of collaboration in parallel with a high-risk PCI study, in parallel with a shock study, we're also going to intrinsically then demonstrate the value that we really started all this with, which is if we gather consistent structured data elements across a whole space, we take the accrual of knowledge to a whole new level by sustaining a poolability that we would never otherwise have. And again, in this case, this is not poolability towards device A versus device B. It's poolability about access technique and bleeding. And I think as a demonstration goes, that if across a device ecosystem, we recognize, particularly for safety data, that if we're consistent about just collaboratively collecting the same structure across industry efforts, FDA trials, good practice registries, et cetera, that we raise the level of the water for everybody's boats to float in just by being consistent. So there's another real aspect to this small bite, but the fact that it could follow multiple avenues even within 2021 is perhaps the biggest illustration of what a lot of our focus and work in this whole team has been.
Yeah, no, thanks, Mitch. And actually, your comments, which are quite important, give me an opportunity to underscore something, which is that, there are three different areas that we're looking for feedback today. One is the longer range vision of the trial, and Chuck and Navin, your input is extremely valuable there. The second is maybe just step all the way back is the vascular safety module itself, just the CRF module, and that element could be used in a variety of settings, as Mitch was just saying, which is to look for that as an element of the lean core CRF that Bill and Ron and Mark have been working on. And that could be employed in registries, clinical trials that would also allow those data to be uniform across trials, and that we hope would come out of this. And then the third component is what we'll talk about next, which is to develop some initial data collection to inform that aspiration of a clinical trial. And those three things are actually all separate. They're obviously can be seamlessly integrated, we hope, but they are separate efforts. And so it would be helpful too in this particular session with maybe 10 more minutes just to see if there's any feedback on the module itself for the CRF. And whether for those of you who are running clinical trials on the call, those of you who are developing registries and have well-tried registries, whether the module is something that fits as an add-on to your data collection that might make sense. Are there things that Mark should add to it? Are there things we should take away? Do you guys have any suggestions for us?
Quick reference, Sami has posted it in the chat, so feel free to download it and look through.
Mark,
Yeah,
out. Go ahead, Alex.
So I mean, I think it's excellent, and I think the value of the vascular bundle is both that it was very well put together, and it's also simple. So you didn't put down 30 different interventions, and most of these have already been independently validated in one way or another to varying degrees, and so I think it's very doable. I think this step design is also good because, for instance, like let's, as Chuck knows, let's take the Impella. It's not just about putting it in safely. It's how do you suture it in? How do you monitor it if it's in for a day or two or three? And how do you take it out? And so some of that, to have to think through all of those pieces, how each one of those is going to impact the other. And I also like, very much like the whole idea of under the umbrella of a quality improvement design idea, because then again, it allows centers to realize that we're just going to make ourselves better. And if everybody can show, if we're able to, that everybody is getting better, then that, offers a different level of validation to the, to the interventions. But I think in the data collection, Navin made a lot of good points, as did Chuck. There's going to be a lot of things that are going to complicate this that we have to be careful about. But even as you just pare it down and simplify it in the way that Navin discussed, I think, as we roll through it, we'll have to think through not just how it goes in the cath lab if a device stays in, but the other steps which are going to impact whether there's bleeding or vascular complication and things of that nature.
So David, the one thing I'm sitting here thinking also that I think was a great point about ECMO is with non-ECMO, are we, and Mark, I'm just trying to think through your forums, but are we in a position to actually capture what I'll call the additive vascular access? So the degree to which not just the device that's the mechanical circulatory support, but if we put the diagnostic and or interventional tube through that sheath as opposed to through our wrist, as opposed to, and I know we do capture whether there's a wrist, a radial access, or an additional femoral access. But are we getting French sizes, or is there really meaning to the cumulative vascular French attack or something? Just something to think about. And with a swan, again, we have on the one hand a smaller device that's in a vein. On the other hand, if it goes into a leg, then we all know it's not impossible, unless you're using ultrasound, to poke an artery. So just thinking about the cumulative vascular safety is not something, at least to my memory, and I didn't make every single call, but just to me, that rang a little bell that we might revisit and think through.
So I think the way the form is set up currently, you could easily just sum, it's designed to be used for each arteriotomy. So you could easily just sum the French size for each arteriotomy with a date and time. That's a quick fix, but yeah, it would be easy to capture.
You called the French connection or something like that. The greater cumulative French you have in is related to your mortality or something.
I love the French, but just not in shock. But I do think, the point of that comment is that, the devil's in the details, and it's so painful when we see the data come out and it's got like a million confounders, and then someone's, calling it bark bleeding. I mean, you guys should come up with shark bleeding, because it's a totally different definition. It has nothing to do with bark, and the transfusion requirements are there for other reasons for these critically ill patients. And so, it's why the AMI shock group, I think, really lends itself really nicely, because as soon as you get into the dilated cardiomyopathic shock patient, I mean, you're in a totally different world. And I do also wonder, actually, have you guys started thinking about, you're thinking about this mostly from a percutaneous perspective, but so cut downs and all the other aspects of care are out of this study, or are they included somehow?
Not intended to be included, but again, Naveen, that's something that we, I think the ultimate evolution would depend on, again, on resourcing and where the sort of most interested sites are coming from, and we can adapt because it's important to all the domains. But at the moment, it's really focused on access in the cath lab.
Yeah, I mean,
So I'll share a general rule.
Sorry, I was just going to say, in our shock algorithm, I mean, for dilated cardiomyopaths, we go straight to an endovascular 5.5. So it's surgeons who are doing the access and everything. So, and also a lot of centers, are just beginning to pick up ECMO in the cath lab, and vast majority are still in the surgical domain. I've got trauma surgeons who are pushing interventionalists out of the way to put in ECMO. So, just keep some of those confounders in mind as well.
So one just oblique footnote, but just a consensus that we reached when we honed down NCDR TVT registries to the lean mitral, lean aortic valve registries. One of the things that was a quick consensus across all stakeholders was, for events that are less than 2%, then those are not going to be your major confounders, and don't tear your hair out. So one question would be, where would we be with cut downs in 5 and above? If that's reaching 5 or 10%, then we probably ought to accommodate it. If it's in 1% or even less, then this may not be the moment to take that dive.
Yeah.
Yeah, one other comment, David, just on the module. As I was looking at it, you might want to have a field in there for the sequence, not just the largest French size that was used, but I mean, you're looking at this through the whole hospitalization, not just the cath lab, right? So if somebody starts out getting a balloon pump in the cath lab, they go downhill, then they get escalated to Impella, or they get escalated to ECMO. I think you want to capture the number of exchanges to get to, and not just the maximum French size, because every time you instrument, you increase the risk, of course.
Yeah, no, excellent point.
Just wondering what people think of the notion that if somebody comes from intensive care with a femoral arterial line that can be wired, in order to then put in a percutaneous circulatory support device. Does that not belong in this set? Because right now I think that's outside, not inside, if there's existing access. But Chuck, along the lines of what you were just describing, I think serial access in the same site, or even pulling a balloon out of one leg to put an Impella in the other. These are complex vascular settings. You want to heparinize, but are you sure the old site's really closed enough? So again, just something to think about. Is that something we want to exclude just to keep the first bite clean and small? Or is there an other category that would be worth at least characterizing
But
for complex?
Yeah, but isn't the endpoint during that index hospitalization, it's not just cath lab complications, it's for the whole hospital admission, right? So
yeah,
you got to include stuff that happens in the ICU, I think, as well as the cath lab, because you really want to know if maybe escalation is going to show that, wow, the bleeding is so excessive when you escalate, it offsets the benefit of whatever you got on the hemodynamics, or probably not, but at least it's a contributing factor maybe to help, that people should be aware of. Okay, if I'm going to escalate, this data has shown that if I pull the balloon pump out and escalate up to ECMO or escalate up to Impella, this is the kind of bleeding that it's going to bump up. And so it's not only the French size, it's what I mentioned before, but you brought up the other issue thing, Mitch, about outside the lab, obviously in the ICU. In the PROTECT 4 study, for patients that stay, this is for high-risk PCI, it's different, but for patients that stay on Impella, the protocol is going to require they come back to the cath lab for removal of Impella as actually a best practice, rather than any kind of removal in the ICU. And so that's something else maybe you'd want to build into your best practices for safety, in addition to ultrasound guided micropuncture, all the things that you did, maybe some other things also related to pre-close and best practices. So we're putting all that into our protocol as best practice on every single closure device, from access to closure and how that closure is actually done and where it's done.
Yeah, we're running a little short on time, guys. So if anyone has something really burning that comes out, feel free. Otherwise, I guess you can put it in the chat and we can carry on.
Yeah, and I'll just make a quick point here. I think, Dr. Simonton, Dr. Kapoor made some fantastic points about the step wedge design. But if we hone down on a very small population like the AMI shock, the step wedge design will continue to have underpowering, statistical issues to look at differences. But that's something that, I think this group has mentioned previously, but, it could be a bigger concern with a more defined select population.
Yeah, it's always a problem as you limit your net population.
Ultimately, Goldilocks will prevail, and we'll find the right balance. But thanks, Chuck. Those were also good comments. We've been thinking about those issues, and but you're spot on.
Okay, I guess we don't get like distributed to other sessions like before. So I guess I'll hand the torch over to my man Alex here, and Alex and Dave to move on with session 3, the development of a network coalition for pilot registry.
Great. Thank you very much, Ian. Let me share my screen. All right. Does everybody see my slides? Thumbs up. Okay, great. So we're going to talk a little bit about building a network coalition. But before I do that, I just want to talk, about 60 seconds about what our networks group was doing. So I think, one of the challenges overall of our networks group was coming up with ideas, but without any, authority, obviously. And so some of what we put together was this concept of perceived better practices, which I don't remember who came up with that direct quote, but I really like that. And so one of our initiatives which I'm not going to cover here, but I'm just going to mention to set the stage, was we talked about what our perceived better practices were for a shock protocol, a shock team, a shock center, a shock network, which I think is important as we go further as a larger CSRC to put down on paper. And in parallel, Alistair has just led a RAND panel where we impaneled a broad group of international people to kind of lay down what those perceived better practices are. And I think that's important to then have some idea of what do we think that is before we start identifying what sites are going to be better, best sites, and also discriminating between what a perceived best clinical practice is versus a perceived best research practice, to distinguish between sites that would be expert, so to speak, in clinical care versus those that would be poised to participate in clinical trials. So again, just to give a little bit of the background of some of the work that our group has been doing. So the objectives here specifically under the context of this first clinical question of the vascular access bundle was to identify sites that were both interested in and capable of participating in data generation and clinical trial enrollment. And as has already come to the fore in the prior discussions, to have a mix of sites to look at not only to see what current practices are and aspirational practices, but have a broad range of centers to see if everybody can get better and to help discriminate what those best practices are. And again, to distinguish between clinical infrastructure and research infrastructure and what the balance of that is. And then of course, with a lot of things, it all comes down to money ultimately. So, as was also discussed so far, there are already various trials that involve mechanical circulatory support and registries. And I think one of the other additional challenges is to figure out how to build this either separate or within the trial. So, for instance, several of these are AbbVie run or organized trials that are either in practice or will be soon. And so the, one question of mine, which I think will be worth discussing, is, if we're identifying sites for the vascular access bundle, do we necessarily have to exclude all the NCSI, DTU, Shield 2, Protect 4, Recover 4 sites, or is there a way to work with industry to embed this within already existing trials? And then again, we had some discussion about, ultimate longer term down the road, about embedding some of this data collection into the AHA Get With The Guidelines strategy. So just something to think about. I'll lay out there for discussion afterwards.
And maybe Alex, just to highlight there too, I think we're talking about the registry, not trying to introduce the complexity of a superimposed randomized access intervention. This would just be purely using the vascular access CRF module to collect identical data.
Correct. So this is all, thank you very much for that clarification for just the, the vascular access bundle, and to think about, how we can collect this with already, within already organized data collection. And so again, as sort of we'd already discussed, what is the reason for this? As I think everybody on the call knows, there are very highly variable vascular access practices across different sites, and they're highly variable outcomes. And there's also high variability of the patients and the circumstances and the device and the multiple access sites. Again, following up on the discussion we just had, that would have to be simplified. And this translates into a lot of variability in bleeding and complication rates. And then I think one of the other things to look at is, the site selection. So as Dave and others mentioned, if you have sites that are already, quote, expert and have very low complication rates, you may not be able to show much of a difference in an adoption of a vascular bundle. And ideally, it would be good to have sites of at different levels of capability and different levels of experience. One issue to discuss is, whether this would be competitive or synergistic, and how we make that so with other ongoing trials and registries. And then, of course, the whole concept of funding and what is the carrot to sites to participate, particularly with a lot of sites with COVID may have had some leaner data collection capabilities. So, then pivoting to concrete next steps is, again, hammering out who is interested, what sites are capable and interested, and perhaps within existing registries or to collect this data and follow the vascular access bundle, or other aspirational sites that are not currently involved, which really provide perhaps virgin territory to start from scratch. And some of this involves what are the current practices, as was discussed, to then evolve into the full bundle collection. And then again, cost funding. And I didn't touch on here, but ultimately, probably worth some discussion now or offline, follow on what the timeline from start to finish this is going to be. So I will stop sharing here and open that up. I don't know if Dave, as my co-chair, you want to jump in with some thoughts before we open it up to the group?
Maybe only to say that our hope is that over the next 50 minutes or so, we actually can kind of roll up our sleeves and get fairly granular to talk through some of the issues about, who on the call would be interested in introducing just the vascular access CRF into existing registries and collect data for some period of time. What would we need for infrastructure to do it? Would any of the trialists on the call be open to introducing that module of the CRF into their trials? And then talk a little bit, if we were going to start up a pilot registry, as separate from any of the other ongoing efforts, what people feel like the funding would need to be for the individual sites, and really see if we can come out of here with a clear direction. And so maybe we'll open it first with a fairly focused question of just from those who are leading trials in this area. Does introducing the CRF module that Mark displayed, is that something that seems like a reasonable thing for you to consider?
I'll jump in, David. I think as far as industry and the other people and the other companies, please speak up. But I think from an industry perspective, on the registry front, it could work pretty well, because we could try to, harmonize what we're collecting with the lean CRF, so that data would be available, maybe even extractable, so you could use it for your own analytics. We have to figure out what kind of contractual thing we could work out there, but I think that might be pretty easy. The hard part is the randomized trials, because if we have a center and a randomized in, say, Recover Forward, the shock trial, we really wouldn't want them to be in this particular registry, because we want them using best practices on every single patient. They'll be randomizing. The idea is to randomize every patient that is eligible for the study, and there's highly prescribed best practices in the protocol, so that at the end of the day, we have a very low vascular complication bleeding rate in the trial. So we wouldn't want them to be in a study where they're transitioning from standard of care to best practices. You know what I mean? We want it to be that way from the get-go. I'm sure you can understand that. But for sites that are not in the RCTs, that are in one of our registries, I think it could work really well.
Yeah, and I guess, Chuck, maybe too, just to clarify again, I think the aspect that we're talking about right now is, simply if you are going to, in your trials, collect data about how the arteriotomy was handled, would you give consideration to collecting the same data that Mark displayed in the CRF, so that you could actually have those same data? We could compare aggregate data from trials and registries, so that we would at least be collecting the same information.
Yeah, I think absolutely. I think they overlap a lot anyway. They probably overlap 95% already.
Yes.
Yes.
Actually, some of the things I suggested that I would put in there are things that we're going to be putting in there that you said, oh yeah, we probably should do that too. So I think it's a great, collaboration. And it's just like the ARC. Why would we not collect, ARC defined endpoints? This is the same sort of thing, really. So we can all share our different safety outcomes and have it be consistent in terms of the data fields. Sure.
Yeah, so Chuck, that couldn't be more on target. And David took the words right out of my mouth, that if the safety module, as we think about it in this discussion, frankly, was probably going to be a subset of what you would be collecting anyway, largely overlapped with what you would be collecting for the trial. Again, the demonstration, just by fine tuning, tweaking that 1% or whatever of other information so it's the same, gives us an opportunity to show that as long, even when it's for very different purposes contextually, if we all simply collect the same minimum structure, there's a whole other level of evidence that we can accrue about the safety of or vascular access. And again, if you have sites in your trial who are using best practice 99% of the time, and on the launch of the safety module with a wedge step, we have sites who are using it 40% of the time, who then escalate. It still will help anchor where we're aiming best practices to be in terms of safety for patients in this space. So it becomes a really unique demonstration of just what consistent, particularly safety data collection, can mean to knowledge in a space.
Okay, and this is Bram Zuckerman. Let me just say, from a regulator's perspective, I would agree with the comments made by Chuck and Mitch. We would be very interested in developing this global case report form such that it could be readily recognized by FDA, be utilized as one module in a registry or in a more sophisticated RCT, build upon that module. Fernando, do you want to build upon my comments from the regulatory perspective? Well, Fernando is on mute, but certainly we'd be very interested in examining the module and seeing if we can okay it and work with your group, David.
It's terrific. No, thanks, Bram. And actually, your team has been well represented on the CRF development group as well, and we've been seeking input all along the way, but certainly we'll work back. I think the vascular module is the latest of Mark's many enterprises, so we'll make sure that we get everyone's input on it as well.
Yeah, I do see Dr. Shinar from FDA.
We had reviewed the MCS SHOC Lean CRF form already. We'll get some input. So, yeah. And we would be very interested in its adoption.
Thanks, Mayor.
And then maybe from Chuck, your comments about the registries, I think also were very heartening and sort of align with our thoughts too, is that it really would be fairly facile to introduce into registries. And I guess one of the things that we've been mulling over is whether the best approach is to offer the CRF module itself to be introduced to existing registries as an add-on for some period. It wouldn't even have to be in perpetuity. It could be for a defined period of time for data collection, or whether a better approach is to, use interested sites from a variety of registries who might come together and just create a focused pilot group that would be a separate registry. And either of those pathways would be workable from a standpoint of data collection, but obviously leveraging the infrastructure of existing registries makes a lot of sense for efficiency. I wonder if folks, it looks like we may have lost Naveen to save a life in the cath lab, but do folks have input on that?
This is Naveen. So I'm still here, still listening in, just in transition from one lab to another. But no, I think that the idea of piggybacking onto our shock working group registry certainly is one that we would definitely want to look at. It certainly makes a lot more sense to me, in terms of adding to our existing infrastructure, which has now grown pretty immense. The operations team is certainly one that can look at that. So yeah, we'd be very open to that.
So David, another layer of this that we might toss out that frankly might also give an opportunity to mix ideas across, sites that maybe Abimed's looking at, sites who are already existing registries, is ultimately the first step. Really, we're going to need some beta test sites, some sites who can take this sort of first iteration and actually walk through it and feed back what works, is formatting, very, very typical sort of early phase beta testing. And that's where motivated sites from multiple different origins working together, I think would also be a great way to cull ideas into the very final end product.
Yeah, that makes sense. And I'd say from the C3TN perspective, it'd be very easy for us to integrate an additional module into our CRF. I think this particular area is much better fit with cardiogenic shock working group, because you guys you're the ones creating the holes, so we're just trying to stick our finger over them and stop the bleeding upstairs, but we don't always do a good job as you. But I think we certainly could, and I think too, it makes sense to use existing infrastructure for cardiogenic shock working group if that ultimately ends up being a good fit for you. But we also could support the data infrastructure from C3TN if that were the option that was best. Other ideas from people on the call? I think, ultimately this avenue might also blend in well to all that we're considering for the AHA registry. I think we're hopeful that we might be able to begin data collection for this particular purpose for the pilot and the beta testing, as you're describing, Mitch, on the landscape of a few months, which may be in advance of where other registry ideas that we're all working on fully mature. But I doesn't mean that then the module can't be integrated into nationwide registries that are broader down the road.
So another thought, David, would be how many already existing mature registries could just take a look at what they're collecting compared to the module, and very potentially, like we were talking about with Chuck and Abimed, it may be that this mini module is frankly mostly just a subset of what they're collecting anyway, in which case there may not be a lot of additional work that they need to do.
Yeah, I'll let Mark speak to that. I think that actually, as he looked across the registries, really the focus on the arteriotomy that I'll say very few, if maybe none of the existing registries were collecting that level of detail. But Mark is the one best positioned.
No, that's right, Dave.
Interesting. Okay.
Yeah, this is really new. It's very focused. That's why we designed it. He could fit it on one slide, but it would be a new module.
Yeah, I think Chuck, I sort of provocatively set up Chuck to answer a lot of stuff on my slide where I showed a lot of the trials, and I wrote, my first draft said competitive, and then I changed it to synergistic, but the reflection of, you know, by virtue of people being in a lot of these trials, which you guys are already running, you know, it makes it hard unless it's embedded within there that these centers couldn't then do another pilot trial, you know, on their own. And then also the concept of, we don't just want necessarily the centers that are just doing the best practices. So that data is important. But again, if we're talking about taking centers from a pre and a post to actually look at other centers too. So it may be sort of two different things going on at the same time that are both existing well together. But overarching, the more we're collecting and looking at the same data, the better to compare, you know, apples to apples. But again, I think the step wedge design piece for looking at centers that may not be your top cherry pick centers for Abiomed or for other, you know, device trials are going to be vitally important, while we also hopefully can collaborate with you to collect, you know, data for centers that you may already be involved in.
Yeah, I think, Alex, that's a good point too. I think that, you know, we you know, can pitch us first, and use existing infrastructure, and then it will be an important goal, certainly in preparation for a trial, to then engage a broader group of sites in pilot data collection. And, you know, one notion we had discussed for the trial was actually having a mandatory run-in phase, even before you enter into the possibility of being randomized, so that to participate in the trial, you collect a month's worth of data, so that then you really have a chance to vet every site and how they might contribute to the trial overall, in terms of actually the heterogeneity you desire at baseline pre-intervention. And so you really can accumulate a rapid amount of data. So any other comments from all of our registry teams? I think our next item to talk about, at least at a high level, are where we would need the funding needs. We decided that funding sources was out of scope for today. That's not our intent here. But we do want to start to get our arms just around the level of support we would need. And honestly, for those who are experienced on the call in registries, and those who might be a site in a registry, what kind of support you think you would need. But before we turn to that direction, just any other comments from a registry perspective of other avenues we might leverage, other groups that might be interested that we should think about reaching out to?
So there's just one question to the whole group, which is, to what degree do we need to think this through a little bit in terms of the percutaneous versus the ECMO communities? You know, you named a number of sites who are obviously more focused in the cardiology domain with percutaneous mechanical support, who are operating registries, whose leadership at least know one another enough to potentially work together. I certainly can't say I know enough about the ECMO community yet. But anybody have thoughts about to what degree it could look similar, different? Where are we with an ECMO safety bundle?
This is Naveen. You know, I think ECMO safety bundle is it's a completely different safety bundle, if you ask me. Mostly because of the heterogeneity of the operators, heterogeneity of the patient population, the heterogeneity of the cannulation conditions are very different and more complex. You know, in ECMO, the mantra is there's nothing wrong with one more cannula. So My personal opinion is that it would be very important to engage ELSO and to have a discussion around the development of a separate and distinct ECMO safety bundle. But I think it's probably separate.
Yeah, it sounds like pretty good advice. I mean,
Yeah, I think probably a lot of the fundamental principles of if we could create a consistent, relatively lean central way of understanding access related safety issues, that would probably be very valuable to understanding that part of the safety aspect of using ECMO. But I guess the more self-evident part is we're probably not ready for prime time on that side of the equation yet. Is that fair?
yeah, and actually to your point earlier, Mitch, actually the one group that I believe does actually collect much more detail around the access is ELSO. So they actually may have pretty robust data as well. I sit on our operations committee, so I'll speak to our ELSO coordinator. And
yeah, so maybe from an aspirational point of view, you know, it would be something to think about in parallel to moving forward with this bundle in the percutaneous application state. And Mark, if we still have you, maybe we could have you circle in. Maybe what we need is more of a dedicated safety bundle module for ECMO as a potential deliverable coming up.
Dave, the only thing I would say to that is that, well, people on this call will know, but it also really struggle to get high quality data. So if you look at the SAVE score, the data completion is only about 23% of the ELSO registry data. So I think that's one of the things that they've really struggled with in terms of progressing, because obviously they have a huge number of sites, but both the heterogeneity of practice and the quality of data collection would be the challenge. Now, that's not to say that they couldn't go to Vanguard sites, but then you again run the problem of going to the high performing sites as opposed to getting, you know, all comers, which is the real world data that I think we're probably after. I mean, it's just a comment. I think it's probably worthwhile. And certainly Eddie, I have spoken to him briefly about it, and I think it would be keen and it would be very attractive to ELSO, this type of thing. I just worry that they would struggle to get the quality of data that we are looking for. And I think Navin's point just about the access and the implications of ECMO access, and also the fact that these patients are, if they're put in, if it's used as an alternative to univentricular support, they're probably a log scale sicker in the majority, so which will then have, you know, impacts on their bleeding rates and outcomes.
And to piggyback on that, Alistair, their case report form is structured much differently than the rest, and so that may be contributing to it. It's pretty detailed. It's just structured differently. It was hard to incorporate it with the other ones because of just how different the data was structured.
I mean, the one group that does have, and people will know more about this than I will, but that does have quite a big focus on safety and very good data collection is obviously ISHLT, and their MCS group, or their acute MCS group, is kind of forging ahead to my knowledge. So it may be that would be another group of people, at least from their ECMO practitioners, and I'm not saying in a competing sense with ELSO, but ISHLT may be a group to speak to about Intermax and see if that's another avenue to explore.
I was just going to add just to add a bit more granularity, those ELSO case report forms are a lot more detailed. Even with a dedicated ECMO coordinator, we're constantly behind adding our ECMO data in. So it's just a word of caution about how far you want to go down this road, because it does put a lot more stress on the sites in terms of human resources imputing the data.
So Sean, has there ever been a discussion of how much of all that comprehensive data is critical, as opposed to how much it might be winnowed down to a much leaner central core?
So I would say at our local level, yes. And our dedicated representative who's brought it back to ELSO, who I assume has brought it back to ELSO, has not heard back. It's a little bit of a slower, less nimble moving organization from my 100-foot perspective in terms of how quickly things happen. But I know from our site and some of our Canadian collaborating sites with ECMO, that has been a concern that is raised, but no international consensus that I'm aware of on making it more parsimonious.
I think ECMONet we're trying, and that may still be a work in progress. So I think also, as people will know, historically focused on pediatrics. And so I think there's been a lot of discussion about the fitness for purpose for adults, and there have been series of conversations about their data collection. And I think ECMONet are in the process of trying to work through a similar body of work. So again, they may be a group to approach, and they've got a reasonable network of sites, albeit more international than US. But again, you know, that's, I mean, Eddie again would be a good contact for that, and I'm sure.
Great. No, all very valuable input. Alex, anything else that you want to cover on this aspect before we move to talk a little bit about the funding needs?
No, I think, you know, I think we covered all the key highlights, and so we'll move on to the easy part, funding.
Yeah, no, I know. You know, I think the again, we don't need to talk about the sourcing, and I think also to some extent the infrastructure isn't really our focus, because I think we have some ideas of what that takes, and also maybe able to leverage existing ongoing efforts. And so I guess I'd ask for input on whether people think that we would, for a focused pilot, if we were to do it even for a period of a few months of data collection, whether we would need site payments, whether sites would need a separate payment to contribute the module. And if so, what your gestalt is about what people would be looking for. And Alex, you feel free to chime in too.
Yeah, I would just be curious to hear, you know, what, again, I think, as, you know, several people have mentioned, some of this is already collected. So the question is, what is the pain point of having another form or getting data that's already there and putting it into another, you know, registry, both for sites that are already doing it and then for sites that are not involved, what that would entail depending on their level of infrastructure.
So, you know, one of the things about the vascular bundle CRF is that a lot of the data that you guys are hoping to collect actually doesn't often get collected. So I think, you know, and this is variable across cath labs, et cetera, but, you know, depending on how much detail, you know, about micropuncture and where the access was it ultrasound guided or not, you know, I'm not sure how much of that actually is readily collected in consumable format in cath labs. Some cath labs just do ultrasound all the time. Some do it whenever the operator asks for it. I don't know that it's actually documented as clearly as one might hope. So if it's not documented clearly, then it's going to be a bigger lift for some sites, because they're going to now need to actually start collecting that in their cath reports and in their documentation. So I would just keep that in mind in terms of how heavy the lift might be at specific sites, even if they have an existing registry data set. It really depends on the elements that are not being collected in the EMR.
Yeah, no, spot on, Naveen. I think you're.
It is billable though, isn't it? It is a billable procedure code. At least I thought.
Ultrasound is if you record the ultrasound.
Yeah, no, I think we're really focusing not again, not on the implementation for the trial, but just on the registry itself and what people would be looking for. And Naveen, certainly if you have a gut instinct about what people would take, you know, I will say that I think if it were for a focused period of time, um, you know, we could probably integrate it into C3TM without a site payment. But I acknowledge that there's a breadth of experience, and I'm still interested in hearing from others whether what people think is
Yeah,
important.
I can speak for Shock. I can speak for Shock Working Group. I think you know, I agree with you, David. I think that, you know, if it's for a focused period of time and, you know, and again, as long as the data is readily available in some formats and existing records, it's certainly possible. I love the idea of a pilot. And I think, you know, getting a few sites to, you know, just basically execute a small pilot to make sure that you work out all the kinks is one thing. The only group that I can't speak for are all the coordinators who collect all the data. and you know, as you know, that's the group that we lean on to basically do an immense amount of data sourcing and then you know, cleanup and the queries and the missingness. And so I would say focused,
Yeah.
brief pilot, doable. Anything beyond that, you're going to start needing to figure out some payment.
Yeah, I think for academic currency as the starting currency of note, I think one of the key questions is going to be what sort of volume over what period of time are we really talking about laying at the feet of the coordinators for in-kind work. If it's 2 a month, it's pretty different than 20 a month. Obviously, if it's 1 every other month, then at the end of 2 months, we aren't going to have a lot of data. But
Yeah.
I think that's something that's probably identifiable. I think, again, if there's an elite initial handful of sites, 8 to 12 sites who are willing to beta test this, carry it through first aggregation of data, and the only reward we can totally offer would be the first set of authors to publish. That also would mean they're the most experienced team we have in moving it forward for parts of other studies that might actually manage site payments differently.
Yeah, I imagine for most of it, it's probably on the order in the, you know, 15 to maybe 25 per month. And it could be for a short period of time. You know, we had to figure out what that is, whether that's 1 month, 2 months, but we may be able, if we get a reasonable number of centers, at least, particularly for your beta testing notion, Mitch, of just testing it out and getting a set of pilot data that may be feasible.
Yeah, I mean, just back of the napkin thinking, if you had 10 sites who could each actually get 15 patients in, what does that 150 patients likely represent in terms of the heterogeneity of the landscape, if nothing else? Because this would clearly just be to capture current standard of practice. I think, again, the slippery slope, as was mentioned earlier, is if the 10 sites who were really the SWAT team who could lift this beta test off the ground are the best 10 sites in the country, and they're doing this all 99% of the time anyway, then we'll get data, but it's not going to have the range, if you will, of outcomes or practice patterns. But I think thinking in some sort of space like that, what's in it for the sites? And if it's not money, can the burden be maintained low enough so there's not an outright cry for money, but some other reward be put on the table, related to the data and a more academic dimension.
Mitch, that's my concern too, that we're going to get the best of the best sites. So the practice delta and the outcomes are going to be skewed. Is there a way that there could maybe be a hybrid approach where you take a few academic sites, but then pre-select, let's call them non-elite sites, you know, rather than using another, so at least we can get a little bit of spread in the data, so it's not all, it's not all the same, so to speak.
Yeah, so Sean, just thinking completely off the cuff, but given the whole conversations we've had through the day, I almost wonder if instead of just sites, we could identify communities who have larger and smaller hospitals within, or something that would help us have more of a range, but nonetheless pull everybody together in a sort of collaborative endeavor.
Yeah, I think it's certainly, there are a number of goals for the pilot, and there's some goals that would still be served by a focused, rapid implementation in some experienced registries with dedicated sites for the academic investment and really setting the stage for the randomized trial. I think if we think that it is a necessary high priority to really reflect the full breadth of practice in this initial effort, then we definitely need to go more broadly in the community, as you say, Mitch. And I think for that, then you would need funding. I think that those additional sites that are going to participate, my instinct is that they would need support in order to be able to collect the data.
So one other, sorry for another sort of random thought, and Chuck, you may know the answer to this, but I wonder if there's a value proposition here for hospitals that could be thought through enough to show, for instance, Chuck, if you're thinking of routinely taking patients back to the cath lab to remove devices, does as far as I know, I'm not sure we can bill for removing a device in cath lab time. Do you know if is that something that actually the hospital pays for or can bill for to remove the device?
Yeah, there is a removal code for Impella and for ECMO, but it's not massive. Well, I meant not massive reimbursement.
Does the hospital see that as a win or a loss? Does anybody know? I'm just asking. I don't know.
It's definitely seen. It is not highly reimbursable, but for instance, Impella repositioning and removal is over 4 RVUs, so it's not trivial either.
Okay.
So probably not a huge deal. I was going to say, in response to what Sean was saying, I think that's a good idea. Start off with a mix of what you would call experienced sites that already are in some best practices type of registry, like the Shock Working Group or NCSI, and then maybe the other half are sites that have research infrastructure. They've got CRCs, working on, NCDR entries and maybe some other types of more general registries, and select maybe 5 or 10 of those. So you get a mix in your pilot, I think would be a good idea, because that'll also test that other hypothesis is, can you get a mix of sites, and can you actually get these other sites to engage in it? And, these patients are going to be, unless you're in a place that's doing 3,000, a couple thousand PCIs a year, which aren't too many of those left these days, you're talking about a patient a month, right? Going into one of these. So I think you probably are not going to have to worry too much about reimbursing them for one very lean case report form a month. If the PI, the local site investigator, there says, okay, we're doing a lot of other research. This is to do the right thing. It's going to take, less than a couple of hours of an FTE to do this every month. You probably could do that pilot without needing, funding. Beyond that, I agree, David. I think you'd have to, if you step it up, you're going to need more funding. you need a little bit of funding for the registry going forward.
All right, all helpful. And, I think it's fair that we might emerge from this with the conclusion that we do need funding to really fulfill our scientific goals for this first effort even. I think that's why we're having the conversation, is really just to come together and decide what we need. And then if we do need the resources, then Mitch will figure out how to get them.
Vegas, baby.
I know. You can't win the Powerball anymore, I guess. So.
Get a Robin Hood account.
You beat me to it, Ian.
Sounds good. All right, Alex, I think back to you if there's anything else you want to cover. I don't think we have to go longer if we've covered all the areas. We actually made good headway on all of the major areas.
No, I agree. I think we covered all the, I tried to set up some topics for discussion. I think we got all of them covered, both uncovering what the challenges are and what the potential solutions and next steps. So I don't have anything further. Thank you.
All right, fantastic. Mitch, are there any other areas you want to make sure we cover? I think I'll just say, I think we've gotten some fantastic feedback on the trial design that will be immensely helpful as we continue to refine that. I think very encouraged by really the support from all the stakeholders, that from the FDA, that this makes a lot of sense to you. I think from our industry participants that this could fit into clinical trials, again, just for the data collection in the CRF. And then as well, I think there are a couple of registry teams here that would be willing to build in the CRF module to our registries for a self-limited period to conduct a pilot. And then we can, the part that we'll noodle on is how we might seek a broader group of sites, as Sean was suggesting, and what support we might need in terms of funding, if at all, to achieve that. But that is a pretty good pathway forward.
Yeah, David, I think you covered the ground. I guess I'd just remind the group that we have sort of this near-term window between now and the CRT meeting, where reporting back on our thinking about this will come down to, what do you think the core messages should be? I definitely agree, circling back to all of the partners, all the constituencies who have spoken up, industry, FDA, registries, AHA, et cetera, to have people's thoughts come together as much as that can be drawn together into a concrete path forward will make, I think CRT will have a broader visibility. This is really, today is focused on a working group, but I think at CRT, the platform will, like the Sky CSRC, it'll be a broader audience. So I think to what degree we can pull this together between now and over about the next, whatever it is, 5 weeks, would be a very exciting option.
Alistair, anything else I know from either from your perspective internationally, or from all the hard work you've been doing with Alex from the networking group?
No, I mean, I'd guess a lot of this is focused on the US. And as I've said to you kind of and others on several occasions, I would be very surprised, and I know there is appetite for this type of work and to collect better data in the cardiogenic shock space across Europe, and to harmonize at a degree. So I think, the focus has been on the US, but, if we are struggling both with the heterogeneity and indeed the number of sites following a pilot, I wouldn't necessarily limit. I accept that creates issues with GDPR, et cetera, and practice, but I think that the more real world and heterogeneous we can get, probably the better information we will glean, and bigger delta in practice we have the potential of making. So, you know, I myself and others are happy to facilitate that. And then the only other thing I was thinking, just based on what Mitch was saying, was, is there an opportunity in terms of, I don't know if CRT would allow this, but to get some sense of the attendees and reaching out at CRT, because you will get the heterogeneity at that meeting prior to, if we're going to run a session, and see if we can use that as a platform to connect with people who may be interested in enrolling in the registry, and then potentially recruiting into the trial was something else to think about. Can we leverage the CRT meeting in our favor?
I see Mitch nodding, for sure. Yeah, no, it's a good idea.
No, I mean, one thing, he couldn't join us today, but Ron Waxman is probably one of the most generous program organizers around in terms of trying to accommodate special requests or shared platforms, shared physical space when we actually sit in a room together. So, you know, I think if we wanted to construct a specific objective, and Alistair, maybe you could help with this, or help me with this, to reach or to reach out to, you know, potential sites to participate in a safety registry launch or something like that as a proposal. I've known Ron a really long time. I'd pretty much guarantee he would probably do anything he could to help us do that.
Okay, yeah, I mean,
nail down what's the ask.
Yeah, the PR opportunity we probably shouldn't miss, because the timing seems, you know, in our favor. And, you know, similarly, if we are a bit delayed, then Sky, you know, it's just using these meetings to kind of spread the word and build, because if we've got the appetite here and we recognize that there's an unmet need, it's kind of permeating the community to try and engage people, because, you know, I think that's kind of where we could head.
Yeah, I mean, frankly, it might be kind of cool to find a way through CRT to reach out for sites who would be willing to fill out a 1.5-page case report form about vascular access with the insertion of mechanical circulatory support patients over a 6-month, you know, just.
Well, you could even do a pre-meeting survey. I mean, I'm getting ahead of myself, but you could even do, if Ron was willing to support it, you could think about a pre-meeting survey and of people who've signed up to attend the meeting, and see if they would notionally have an interest, if they had a data collection infrastructure, and just get a sense of that pre-meeting, and then invite them to a specific session to similar to this, just to outline it all.
I think it's a great idea for us to chew on.
Yeah. And I think particularly, David, if you and Naveen and Bill, you know, I think if the biggest, most prominent, and Alex, regional and national shock registry networks were participating in something, and were asking, you know, people who want to join us in the first real national approach or international approach to consistent vascular safety data collection and shock, that would be an invitation, might pull in a lot of centers who otherwise are kind of out there on their own.
Yep, we will start the conversation. All right, Professor Gilchrist, you're, as our chair, do you, we'll lean on you if you want to close out and give people an extra half hour on their Friday.
Well, I do think we pretty much, you know, we sort of put together the wrap up into the system already. So I'm not sure that, I think we're sort of exhausting our discussion at this point in time, unless someone else on the line here has a burning question or door to open up that hasn't been opened at the moment. I think we got a lot of interesting information passed back and forth and heard from a lot of different voices on what we might look for going forward. A lot of heads are bobbing. Anyone want to stay on longer, or do you want the half hour? I give it to you. It's free.
Miller time.
Yeah.
Thanks, everyone. Actually,
Hey, Mitch, can we get these? Are these slides going to come out to everybody from today?
That is usually the plan, Chuck. Yes. I'll leave it to either Simia or Val.
Hi, this is Samia. Yes, we'll have the slides be available. We just have to make sure that we can distribute them publicly.
Okay.
That's generally our track record on that is pretty good, Chuck. So.
Yep. I just want to get going, make sure I've got what I need on my end. Thanks.
Sounds good, Chuck. Anything you need in particular from us, just let us know. Get it to you quickly. All right. Thanks, everyone, so much.
Thanks, everybody. Have a nice weekend.
Be well.
Thank you. Bye-bye.